No, that's a nice reminder that there's increasing need to be thinking about molecular testing, gene expression profiling being still kind of in the validation mode. But there's a few tests that we need to consider, particularly in the advanced disease population. So Georgina, maybe just a quick check on sort of mutations that are important to assay, and then maybe a little even more detail, like in the BRAF context specifically, kind of what do you think of as being the really key features that you need to know about a patient to help guide treatment?
Okay, so now going back to the patient interface, away from the research and what's critical when you've got someone sitting in front of you and you need to make decisions about currently available treatments or even clinical trials, which are still very important. Well, number one, you need to know whether the tumour has a BRAF mutation, particularly a V600 BRAF mutation. There are several different types of V600 mutations. There's V600E, V600K. V600E tends to be associated with younger age, truncal primaries, whereas V600K, on the other hand, is associated with chronic sun damage, probably a high mutational load, although we haven't looked at that data specifically as yet, but it's there. It's there for looking. Scalp, head and neck primaries, all the things associated with chronic sun damage. And then you've got V600R, V600M, and these more rare V600 mutations. So that's number one. We have to know whether they've got the BRAF mutation. Routinely, we do NRAS mutation, and that's because we do trials, although that would not be required for your standard available treatments. I think increasingly we'll be looking at NF1. c-KIT, we tend to, although we do it, it's not as used because there are no available KIT drugs that target KIT. There are some, but really our other treatments tend to be much more tolerable and better and more efficacious, and to be frank, no KIT inhibitors are actually approved for melanoma. But that's the panel we do. If I had to choose, if the one that's critical is the BRAF. You just need to know whether they're BRAF mutant or BRAF wild type. However, in the next 2 years, I'd say that we're going to have to do some of these other mutations as a matter of course. And most centres around the world will do a whole panel of mutations as a matter of course.
Right, and certainly for research purposes that's important. But Jason, maybe a couple comments on the issue of melanoma subtypes and sort of what clinicians' expectations can be when they have a patient in front of them with advanced melanoma or metastatic melanoma, typical cutaneous, mucosal, acral, uveal. I mean, sort of what are the how are you thinking about this genetic testing model and the likelihood of finding something that you can jump on?
Yeah, so this is one thing I would explain to patients is that melanoma is not necessarily skin cancer. And that most of melanoma is cutaneous melanoma, and that's where we see the mutations that were predominantly just described, BRAF, NRAS, NF1. There are other melanocytic or melanomas that can arise in other parts of the body, including acral lentiginous melanomas or mucosal melanomas, as well as uveal melanomas. And we see a different mutational spectrum in those types of tumors. And so for a practicing clinician, it's important to have the sense of that, because in those less common mutations, the incidence of BRAF mutation is much lower. So it's not that it's inappropriate to test for it, but you really should not have an expectation you're going to find it in those. And that's where testing for some of these other tumor types really comes into play, because there is an enrichment then for RAS mutation, but maybe most importantly for KIT mutation in some of these other tumors. And it's worth noting that there's a fair amount of data, 3 phase 2 studies now for KIT inhibitors, and maybe this is a slight difference between Australia and the United States, where our NCCN compendium do list KIT inhibitors as a reasonable consideration. Now, the efficacy is there to be considered, but I will point out that if you look in the KIT inhibitor space, in terms of, you can see many different mutations in KIT as compared with BRAF, and that actually makes a big difference. So which exons of KIT are mutated makes a huge difference in responsiveness to KIT inhibitors, and if you find the appropriate exon mutation, they can actually be almost as effective as monotherapy BRAF. But it's worth noting that just any KIT mutation doesn't necessarily mean you'll get response to a KIT inhibitor.
And as this year's ASCO is going to sort of introduce the concept that moving outside of the BRAF mutant realm, we might have targeted therapies, perhaps for the NRAS mutant population. But how do you think about the rest of melanoma in terms of a foothold for targeted therapy? So NF1 mutant melanoma or the uveal melanomas with their very common GNAQ, GNA11 mutations.
Well, I think it's an evolving role, and I think that based on what we've learned from cutaneous melanoma, this is something we really need to drill down on, and I think it does point out that we haven't cured melanoma, and that there's a lot of work still to be done, especially in some of these molecular subsets. Because we see, not rare, but we see some patients who have good responses to, say, MEK inhibitor in the context of a uveal melanoma with a gene AQ, but it's not uniform. And so what's the rest of that underlying biology, and what combination approaches could we think about? And so I think MEK inhibitors as a consideration for NF1 and for gene AQ, gene A11 are reasonable, but they're not the be-all, end-all, and that points out that we really still need to focus on those clinical trials to investigate that population.
I totally agree.
I want to emphasize that because you know, we all thought that MEK inhibition would help with some of these, you know, particularly gene AQ, gene A11, and really we're not doing anything. We're not getting the right pathway, we're not hitting it hard enough, and we're just not making any impact in uveal melanoma. So we've got a lot of work to do both on the immunotherapy front, but also just on the pathways activated in uveal and how best to target them. It's an unmet need.